Your first patient presents with an obvious shoulder deformity, and you're like, must be a shoulder dislocation. How am I going to sedate them? What am I going to do about it?
And in the next room, you have a patient presenting with lightheadedness, and you find that they have intermittent bradycardia. And you wonder, should I pace this patient?
In this episode of Critical Decisions in Emergency Medicine, we will talk about procedural sedation and analgesia, specifically choosing medications and preparing successfully to decrease the risk of adverse events.
We will also talk about symptomatic bradycardia, what are some of our options for medical management, and how to perform transcutaneous and transvenous pacing.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices mostly in Florida, a little bit in Ohio, and a little bit elsewhere.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the August 2025 episode of Critical Decisions in Emergency Medicine podcast. Critical Decisions is a fantastic publication by ASAP, and each month we discuss 2 lessons that are bread and butter emergency medicine or things that are cutting edge.
In addition to the 2 lessons, there are also a lot of other features such as the Clinical Pediatrics, the critical cases in Orthopedics and Trauma, and as our listeners know, one of my favorite features, the LLSA Literature Review.
So for our first lesson, pick up the pace, Symptomatic Bradycardia. Thank you to Drs. Nicole Tzinska, Nicholas Sachs, and Alfred Sacchetti for writing this article. Bradycardia is a very common ED presentation, and we need to know how to identify the underlying cause and when to intervene. So first things first, what is symptomatic bradycardia?
We know that it's a patient presenting with a slow heart rate and having some signs of inadequate organ perfusion. Maybe they have symptoms of diaphoresis, syncope, or even in very severe cases, cardiac arrest. It's less so about the actual heart rate number, but any sort of bradyarrhythmia that causes, again, these types of hypoperfusion symptoms. The other category of patients we should think about are those who have some high risk of decompensation that we need to consider for urgent intervention.
Makes sense. So what are some causes of bradycardia?
Or maybe a less severe etiology would be a vasovagal stimulus of some sort. And these are generally a transient bradycardic event that patients could even syncopize from, but they're rarely persistent bradycardia. When we're dealing with, of course, more severe causes, it may be a toxin or drug-related process, such as from calcium channel blockers or beta blockers, but also from tricyclic antidepressants, digoxin, and clonidine. Don't forget about acute MI that involves your RCA. That can, of course, produce a second-degree AV block. And then there's also other medical conditions like mixed edema coma and hyperkalemia. The lesson does include a great table that also includes the specific treatments for these medical causes.
Speaking of treatments, what are our options for medical management of symptomatic bradycardia?
Well, if it is caused by something like hyperkalemia, of course, we want to treat the actual underlying cause. But speaking specifically about treatment of the bradycardia itself, often we reach for atropine. And this is generally more effective if you're dealing with SA node dysfunctions, but you can try it in higher grade blocks. And we can give it as 0.5 milligrams every 3 to 5 minutes with a total max dose of 3 milligrams. Really, if you're not seeing any response with the first or second dose, you probably need to consider some other agents. And that can be isoproterenol, which is a beta agonist that can increase the heart rate and contractility by reducing the refractory period and shortening the AV conduction time. The caveat is if you're dealing with a patient with concerns of ACS, you want to avoid this because this increases myocardial demand. Now, most of us are reaching for dopamine or epinephrine if they're not responding to atropine or they're unstable because you want to, of course, help support the heart rate while you're also getting set up for possibly pacing.
Got it. So when should we consider transcutaneous pacing?
Really, this should be in any patient who is unstable. And the idea is that that will serve as a bridge to your more definitive therapy. It's really effective, but sometimes the limitation is that the patients cannot tolerate it because it can be painful. Now, even in patients that you're considering placing a transvenous pacer, sometimes starting the patient initially with transcutaneous pacing can help improve your success in placing the transvenous pacer because by augmenting and increasing the cardiac output, it'll be easier to float the pacer. But the caveat then in this case is you have to try and distinguish what is the transcutaneous pace rhythm versus ultimately what are the pacer spikes you see when you're floating that transvenous pacer.
Got it. Any tips to transcutaneous pacing?
Well, you can place those pads either anterior posterior or in an anterior lateral location. You do want to make sure that lateral pad is on the chest and not on the abdomen. You can refer to the figure in the lesson to take a look at that. If you're doing transcutaneous pacing in a patient who's awake, you want to start with a lower current and increase upward until you get capture. If the patient is unstable, then you want to start with a higher current, maybe even with 80 milliamps, and titrate down until you find that capture threshold. Then you can increase by 10%. In terms of confirmation of capture, of course, you're looking at the actual electrical discharges on your monitor, but you also want to make sure you have a palpable pulse with each of those electrical discharges and, of course, a improved perfusing blood pressure. And your pulse ox can be a great tool for that, or you can use a Doppler ultrasound.
Those are great tips. So how about transvenous pacing? When should we do that instead of transcutaneous pacing?
Good question. And I think this is often a point of debate also. When is that threshold for placing a transvenous pacer? Well, if you are dealing with something that does not have an obvious reversible etiology, then certainly the patient may need a transvenous pacer to, again, ensure their stability and figure out a long-term solution for it. Or if you're needing transcutaneous pacing for an extended period of time. The other consideration that we have in the ED is that you have electrophysiology readily available. If you do in your institution and the patient can be whisked away to the cath lab for this, then you may not need to go through the whole procedure yourself. Certainly, it's something you can discuss with your cardiology consultants, but generally, it's actually better to place this during a more stable period of time for the patient when maybe they're having a non-bradycardic episode, because again, that's more likely for you to have a successful placement.
Makes sense. So let's walk through the steps of placing a transvenous pacer, because I'm not sure about you, but for me, it's not like an everyday procedure. First things first, what equipment do we need?
Absolutely. It's a good refresher for sure. So a lot of times we have these pre-assembled transvenous pacer trays. If you don't, the equipment that's generally included in them is the actual introducer or cordis, which is your central venous access. You have the pacer wire itself that has a balloon tip with an associated syringe that's specifically made to go with that to inflate the balloon. You have a sterile sheath cover to keep that wire sterile. And then you have some adapter clips to connect to ultimately your cable and some alligator clamps. Then separate to this kit, you're going to actually need your cable, the generator box, and maybe even some extra batteries. And don't forget, you're going to need other supplies that you typically need for a central line placement, like your suture, your dressing, sterile cap, gown, and gloves. Or sometimes people may even just open up an extra central line kit so that you have access to all of those equipment as well. The article also has a great picture and a list for you to refer to.
Lists are awesome. All right. So let's say you have all of your equipment. Great tip on where to get them from. What do we do next?
Well, next, you're going to have to figure out which access you want to use to place this. Most commonly and most optimal is the right IJ, since it's a straight shot to the SVC and to the right heart. An alternative is the left subclavian, which is a pretty smooth direction as well. You can also place these transvenous pacers from the femoral vein to the IVC into the right heart, especially if you're dealing with a patient who has a known SVC obstruction, or maybe they're undergoing some other procedures around the head and neck. For the actual venous access part, it's like placing any other central line. Of course, you're dealing with an introducer or cordis that's much larger in caliber. So you want to make sure your wire is in the vein before dilation. You're going to place the stylet in the dilator with the Danya technique. You're going to remove that wire and the stylet. And then what's left then in the patient is this introducer cordis that has a diaphragm that prevents the blood flow out of the patient, as well as a separate infusion port that allows you to give medications.
Got it. where's the pacer wire situation going? What are we doing with that?
Yes, this is the part that will take an assistant to help you because you're going to have non-sterile equipment like your generator box and cable, and then the sterile part that you're working with.
And that's in the checklist, correct?
Yes, exactly. So some people prefer to get all of their wire and generator all set up before they put in the actual venous access. Others prefer to do it separately. Either is okay. Just get familiar with the technique that you prefer. When you are dealing with the pacer wire, dealing with something that's very long, these wires are generally 60 to 70 centimeters in length. And so, of course, it's important to try and keep this whole length sterile in your field. The wire itself has markings every 10 centimeters. And as we know, the distal end has a balloon for the floating part, and the proximal end has connections to your cable. The proximal end is the positive lead, and the distal end is the negative lead. So that's how you remember proximal for positive. Unfortunately, it's not marked by a plus or a minus. There's also a distal connection that has a stopcock, and that's where you attach the syringe. Remember that you can only use the syringe that comes with the wire kit because this is only meant to inflate 1.5 cc's of air, not any larger, because you don't want a bigger balloon in the heart. And you should test the balloon before placing the wire ultimately. There's also that sheath covering that we mentioned to keep everything sterile, and you want to place it over the entire wire before you insert the wire because there's no other way to get it onto the wire after it's in the patient. Now, in terms of the non-sterile aspect, to have your assistant, often your nurse, to get things set up, that is to get the settings on your generator box set up. So you want to select a heart rate, and it's recommended to pick something like 80 to 100 beats per minute because then you'll be able to see via capture quickly. You want to set the current to high enough to ensure capture. So the article recommends 25 milliamps. And you want to turn the sensitivity to as low as possible or even off to avoid induction of any arrhythmias of erratic type of beats. So now you have your generator box set up, your pacer wire connected to the adapters and to the non-sterile cable portion. And the tip is that you hang that non-sterile portion over an IV pole so it hangs over your field without getting your sterile field dirty. And finally, you can actually do the floating or the insertion of the wire portion of your procedure.
Got it. So what do we do during this part?
So to actually insert and float the pacer wire, you're going to essentially insert the wire until about the 15 to 20 centimeter mark, which means the tip of your wire and the balloon is past the end of the introducer. You're going to have your assistant inflate the balloon with 1.5 cc's of air and lock it. Turn on the generator so that you can start watching for capture. You're going to slowly advance the wire, or you're going to see capture, which looks like PVCs that match your set rate, in this case, 80 or 100 beats per minute. Once you have capture, you're going to deflate the balloon, and you can advance another 0.5 centimeter to ensure a good, secure contact with the myocardium. Now, if you don't have capture, though, you want to deflate the balloon. You're going to withdraw the wire back to, again, 15 to 20 centimeters, and you can refloat it. You may need to do this a few times. Every time you move the wire, though, you need to have the balloon first deflated until you have the floating advancement portion inflated to do so. If the patient already is being transcutaneously paced, you can set that to 60 beats per minute so that you can see when you have capture at that higher rate for the transvenous pacer. And then once you have capture again, the other thing you want to do with your settings is you want to decrease the current because you had it set quite high initially at 25 milliamps. And usually you only need less than 5 milliamps to have adequate capture from the transvenous pacing route. But once you find that threshold, you want to increase it by 2 milliamps or double it. So when you're all done with this, you have your wire in place. You want to make note of the depth, and you have to deflate the balloon. It is only inflated during the floating portion, so now deflated. And then you want to extend that sheath covering to keep everything sterile for any further manipulations. You can also even loop and tape the wire to the skin to avoid dislodgement.
And this is when we celebrate, right?
Yeah, exactly. The patient is feeling better. You successfully placed it. Don't forget to get a chest x-ray, of course, to confirm. And then talk with your EP or cardiology specialist to figure out what to do long term. The article also includes some common problems that can be encountered with the transvenous pacer replacement. That's a good section to take a look at.
Got it. Well, thank you so much, Wendy, for going through this article. It is definitely an important refresher about symptomatic bradycardia and how to manage that. It's important to remember that the number for the heart rate doesn't matter as much as the symptoms. Basically, signs of hypoperfusion that can be related to a toxin, drug-related, an MI involving the RCA, or other medical conditions such as thyroid dysfunction or electrolyte abnormality. From a medical management standpoint, we can use atropine as our number 1, isoproterenol as our number 2, and our number 3 would be dopamine and epi. But it's important to remember that in patients who are bradycardic because of an acute myocardial infarction, this should be done with caution because that increases the myocardial demand. In patients who are unstable, we need to do transcutaneous pacing as a bridge to definitive therapy. It is effective, but may be poorly tolerated. It is more likely to be effective if we place the pads correctly. So if they're enterolateral, then they're on the chest itself, and start with a lower current and titrate up as much as needed, despite the fact that it's uncomfortable. Obviously, if we can manage that discomfort, that'd be great. I guess we're going to be talking about that in our second lesson today. However, if there is no obvious reversible etiology or the patient's going to need transcutaneous pacing over a period of time, then a transvenous pacer needs to be placed. You went through the steps of that. Great refresher. It's important to keep a checklist, pick a correct access point, optimally the right IJ if possible, and then prep the wire before placing the introducer and make sure that you know what the connections are. Proximal is for positive. Great reminder for that one. And if you have the luxury of an assistant, then that is definitely helpful. Start with a rate of 100 if you can, and an output of 25 milliamps. Take a moment and take a look at the article for the details, or just rewind what Wendy said and look at common problems encountered during the placement. So keeping up with the cardiac theme, our critical ECG this month is about a 24-year-old female presenting with syncope at rest, which was preceded by palpitations. Otherwise, she's completely asymptomatic. Her ECG shows the classic triad of Wolff-Parkinson-White syndrome, or WPW, shortened PR interval, a delta wave, and a minimally widened QRS complex. It also has this less commonly known finding of pseudo-ischemic changes, which include Q waves in the inferior leads 3 and AVF, with ST depressions in leads 1 and AVL, as well as ST elevation in leads 3 and AVF, with some T wave inversions in the lateral leads V3, V4, V5, as well as 1 and AVL. As we all know, patients with WPW have a congenital accessory pathway that bypasses the AV node, allowing the atrial impulses to arrive at the ventricle sooner, which predisposes them to 3 classic dysrhythmias in order of decreasing frequency. Orthodromic, which is with a narrow QRS complex, AV reciprocating tachycardia, or AVRT, WPW-related atrial fibrillation, and antidromic, which means the QRS complex is wide, AVRT. It's important to remember that in order for you to say that somebody has WPW syndrome, they have to have that classic ECG triad and come in with either an active dysrhythmia or symptoms consistent with dysrhythmia. Just having the ECG findings does not actually count. The article has fantastic images and a great explanation of the pathophysiology. And even more cardiology, our clinical pediatrics case this month is a case of a 15-year-old boy who's presenting with 3 days of vomiting and worsening diffuse chest pain with no other significant history. His ECG is normal, but his stroke is elevated to 2 nanograms per ml, and his UTOX is positive for cannabis. He has a normal chest x-ray, and his echo shows trace pericardial effusion. And of course, he was admitted.
While he was admitted, his ECG showed ST elevations that are consistent with pericarditis, and he had further elevation of troponin. So he was diagnosed with myopericarditis. Now, we often think of this with a viral illness, but environmental toxins can precipitate it as well, such as in this case, cannabis. This can also cause cardiovascular dysfunctions with various mechanisms, and patients can present with tachycardia, elevated blood pressure, coronary vasospasm, and even have a more prothrombotic state, which is really concerning because apparently now almost a third of 12th graders use cannabis and up to even 6% in 8th graders. Whew.
Definitely a lot. The workup includes troponin, BNP, CRP, ESR, procalcitonin, and of course, an ECG. The outcomes of these patients is usually good, but some patients, especially PEDS patients, may suddenly decompensate, either from sudden worsening of their systolic function or an arrhythmia. This particular patient did well after a 5-day stay in the PICU with a negative MRI and no decompensation.
As for the differential for chest pain in PEDS, the most common cause is actually musculoskeletal, so we may think of costochondritis, precordial catch syndrome, and muscle strain. Don't forget about other differentials like respiratory and GI causes.
And just in case you don't talk enough about chest pain at work, here's one more case that's our critical image this month. It's a case of a 42-year-old female with history of lupus, PE on DOAC, end-stage renal disease on dialysis, who's presenting with chest pain and shortness of breath. Her troponin and BNP are, of course, elevated. And while you're trying to figure out how to work her up, she becomes hypotensive. She requires norepi. So, of course, then at that point, you do a CT angio, and she has a, ta-da, massive PE.
Ooh, giving me chest pain as well. So this case does highlight a few considerations in PE, which are uncommon or atypical risk factors, such as intravascular devices like pacemakers, dialysis catheters, especially if they're terminating in the right ventricle, as well as chronic kidney disease. Now, interestingly, the risk of VTE in kidney failure is not mitigated by being on dialysis, despite receiving regular heparin doses and the uremic platelet dysfunction. And even treatment with anticoagulation does not protect from PE 100%, since there can be treatment failure even with DOACs like apixaban. So there are many other venous thromboembolism pearls in this article that you should check out.
Switching gears to something different, our LLSA Literature review this month is an article from Annals of Emergency Medicine in 2022 entitled Update on Emerging Infections from the Centers for Disease Control and Prevention.
This article is specifically addressing updates in STI treatment. And so a few things that have been changed or updated are that nucleic acid amplification tests is now preferred for both chlamydia and gonorrhea infections. And patient-collected specimens are perfectly acceptable if you provide them with good instructions on how to do so. Now, for treatment of chlamydia, azithromycin is no longer first line except in pregnant patients. Instead, we should use doxycycline, 100 milligrams, BID, times 7 days. For gonorrhea, single-dose ceftriaxone is still the antibiotic choice, but we do need to increase the dose to 500 milligrams IM if the patient is less than 150 kilograms, and 1 gram for those who are greater than 150 kilograms. Cefixime is an alternative, but we also need to use an increased dose of 800 milligrams PO, but try to limit this to try to reduce, of course, further antibiotic resistance. In terms of resistance, fluoroquinolones and macrolides are no longer recommended. If the patient does have a cephalosporin allergy, you can use a single-dose gentamicin, 250 milligrams IM, with azithromycin, 2 grams PO.
Great summary of a great article. So keeping up with issues down below, our critical procedure this month is manual testicular detorsion. It's a surgical emergency, of course. This is not going to fix everything, but we should attempt a manual detorsion to improve the chance for viability. There's, of course, a risk of worsening ischemia or creating torsion if somebody didn't actually have torsion when you do that. And again, you're not fixing the problem permanently. Patients still require surgery, such as orchidopexy.
Now, for the technique itself, as we mentioned, we do want to consult our surgical specialist early so that they can prepare for the ultimate procedure, as well as if you're not successful in manually detorsing. You should consider providing analgesia or sedation, or even a spermatic cord block can be considered. For the detorsion technique, we often learn about opening the book. So you want to hold the testicle and attempt to rotate 180 degrees. That means for the right testicle, that would be counterclockwise. And for the left testicle, it will be clockwise. Depending on the patient's response, you may need to rotate even further, up to 360 degrees. Now, if the patient is experiencing worsening pain or you're meeting any resistance, then you can rotate in the opposite direction. Another technique is to apply some traction on the spermatic cord, then rotate. And at the end of this, you do want to get a repeat ultrasound to confirm whether or not you have successfully detorsed the testicle.
Great reminder of an important procedure that hopefully we don't have to do often. Switching gears to ortho, our critical cases in orthopedics and trauma is...
It's an 18-year-old after a rollover MBC as an unrestrained passenger, and he's presenting with significant left lateral and interior hip pain. You actually find that he has sensory loss below the knee and can't move his ankle or toes, but he does have intact pulses in soft compartments.
Imaging shows a fracture and dislocation of the left acetabulum. Acetabular fractures generally occur in high-energy trauma, and they often require a CT for classification and surgical planning. The article describes some fracture patterns based on Judet and Letourneau's system. In this patient, he has protrusion of the femoral head into the pelvis, causing a sciatic nerve injury, and therefore that sensory and motor loss described.
Now, if you're dealing with a stable fracture without displacement, these are often managed non-operative with weight-bearing restrictions. If you are dealing with a displaced or unstable fracture, then you do want to have early operative management within 72 hours to improve anatomic reduction. If there is a hip dislocation with this, that should be reduced within 12 hours. And overall prognosis really depends on the patient's age, the fracture pattern, the quality of the reduction, as well as if there's any associated femoral head injury or other trauma.
So keeping up with things that may require procedures, our second lesson of this issue is Lights Out, Procedural Sedation and Analgesia. Thank you to Drs. Ria Koshy, Parag Mehta, and Joshua Kern for writing this article.
Such as in that hip fracture patient we just talked about, procedural sedation is commonly used to facilitate patient comfort and cooperation. And so there are also other indications beyond fractures and dislocations.
Exactly. Lac repair, synchronized cardioversion, pacing we're talking about. And it's important to note that the correct term that we should use for this situation is procedural sedation, as the level of sedation needed depends on the circumstances, and the patient can easily move from one stage or depth of sedation or level to the other. Sedation can be classified as minimal, moderate, deep, or general anesthesia. The level of consciousness decreases with each, and the rate of complications increases, reaching 6.3% for deep sedation, mostly related to hypoxia.
That makes sense. So what patient characteristics should we consider before commencing with procedural sedation?
When planning procedural sedation, it's important to consider patient-specific risk factors. High-risk patients often include those at the extremes of age, those with challenging airway anatomy, or those with multiple comorbidities. The ASA physical status classification is a helpful framework for gauging overall risk, with Class 1 being healthy and Class 3 or above signaling higher concern. Beyond ASA, a careful airway assessment is crucial. Features such as macroglossia, micrognatnia, short neck, obesity, prior cervical fusion, facial trauma, history of obstructive sleep apnea, all those can make airway management more difficult. A focus history in exam should also cover prior experiences with anesthesia, allergies, current meds, substance use, any conditions affecting drug metabolism. Tools like the Mallampati score provide a graded visual assessment of the patient's airway, which can predict difficult laryngoscopy, difficult intubation, and difficult bag valve mask ventilation. Ultimately, these considerations help determine whether procedural sedation is safe in the ED or if additional resources are needed.
Great tips. Now, how can we minimize the adverse effects of the procedural sedation and analgesia?
Checklists, like we talked about earlier, are a great way to make sure we have everything we need, including personnel, meds, monitoring, equipment, and documentation. A great sample is provided in the article.
Excellent. Now, I have a question for you. How many people do we actually need to undergo and monitor this patient?
Well, I don't have an answer for you. I don't think anybody does. Lots of people talk about having two physicians, one for the sedation and one for the procedure, and a nurse is better than just having one physician and one nurse. But there's a decent amount of observational data that doesn't show a significant difference. What AAM and AAP state is that two clinicians should be present at least. One is the physician, and the second clinician may be a nurse.
That makes sense. What about other monitoring pearls?
People talk a lot about capnography, and it's a useful tool for monitoring patients during procedural sedation in the ED. Because changes in end-tidal CO2 often occur before oxygen saturation or heart rate changes, capnography may provide one of the earliest warnings of hypoventilation. There's a couple of warnings that we can see. Either bradypneic hypoventilation, where the patient starts to have a low respiratory rate, the end-tidal CO2 gets elevated above 50, or hypopneic hypoventilation, where the patient starts to take shallow breaths and the tidal volume becomes low despite a normal rate. And that's when their end-tidal CO2 drops below 30 or drops more than 10 from where they were. In practice, it just adds an extra layer of safety, often identifying respiratory compromise before the other monitors, as shown in several studies. However, there are two meta-analyses that suggested that capnography is limited in preventing oxygen desaturation. That said, lots of EDs use it because it's low risk, non-invasive, and readily available. ASAP actually recommends capnography for use during procedural sedation to closely monitor the patient's respiratory status. Another thing we commonly use is supplemental oxygen and pulse oximetry. Although the pulse oximetry is reliable to monitor a patient's oxygen levels, it's insufficient when used alone to monitor for respiratory depression, as we had talked about, because of the fact that it's going to take a while for it to drop. Supplemental oxygen does safely permit patients to tolerate short periods of respiratory depression or apnea without needing positive pressure ventilation. Again, because it can easily be administered alongside capnography, ASAP and ASA both recommend supplemental oxygen during procedural sedation.
Got it. Now, another question I have for you is fasting. I find it hard to ask people to fast before their unscheduled emergencies.
It is quite challenging to do that. You're absolutely right. The ASA does have some guidelines for elective general anesthesia, which are mostly based on consensus, not strong evidence. And they say you should be fasting for 2 hours after ingestion of clear liquids, 4 hours after breast milk, and 6 hours after solids. That said, numerous studies on procedural sedation have been conducted, and none of them demonstrated an association between increased complications and decreased fasting times. So it doesn't seem like this is something that's necessary for us in our setting.
Thank goodness. Now, what about medications? There are a lot of different agents that we can choose for procedural sedation and analgesia. What are some dosing strategies?
So the article has a very thorough review. I'm just going to share with you a brief one. We, of course, have several classes. There's opioids, benzos, nitrous oxide, propofol, ketamine, and etomidate. Opioids, most commonly fentanyl, provide analgesia, but not really true sedation on their own. Benzos, most commonly midazolam, provide sedation, but not analgesia. Nitrous oxide is not really available everywhere, and it's really important to ensure that it's correctly delivered to the patient only and not the staff, because that would probably not work out too well. Propofol is commonly used due to its short-acting nature, but remember, it does not have any analgesic effect and does cause hypotension in some patients. Ketamine is quite popular because it's analgesic, it's dissociative, which means that additional dosing will not deepen sedation. However, a scary thing is laryngospasm, which can be managed with Larsen maneuver. We're quite familiar with a combo of both ketofol, ketamine, and propofol, which does have several advantages, but not in the pediatric population. Another common one is etomidate. It has a very short duration of action, but no analgesic effect, but also no hypotension, which is fantastic. Something to remember about it is that it can cause myoclonus, which, depending on what you're trying to do, might make things hard if you're trying to do something with their limbs, but also it can freak people out. There's a great table in the article that summarizes the doses, onset, duration, advantages, disadvantages. Definitely worth a review.
Yes, definitely take a look at that table. Now, what about adjuncts that we can consider for procedural sedation and analgesia?
So pre-procedural opioids increase complications such as respiratory depression and vomiting. So if a patient has received an opioid before their procedure, let's say you weren't planning a procedure and you gave them an opioid and then you're like, oh, we're going to have to do this, try to either use a local anesthetic instead of procedural sedation or delay procedural sedation until the opioid's peak effect has passed, which obviously if it's morphine, that's a lot longer than fentanyl. Another adjunct to think about is anticholinergics, such as atropine or glycopyrrolate, especially in pediatric patients, when they receive ketamine to decrease the risk of hypersalivation. Data is not super clear there, but people find that helpful. Antiemetics, such as ondansetron, may also be used in patients receiving ketamine, especially the super high risk for vomiting, which is the adolescent group, to decrease that risk.
What about considerations for pregnant patients?
So pregnant patients are considered high risk because they have difficult airways, they have airway edema, and so on. Meds, however, are generally safe, like midazolam, ketamine, opioids, propofol. Now, there is some conflicting evidence about the risk of teratogenicity with benzodiazepines. And then, of course, propofol is going to cause hypotension just as much as the other person, probably even a little bit more in pregnant people, since they live at a lower blood pressure.
What about pediatrics?
Well, children under the age of 6 are at the greatest risk of adverse events, especially those below the age of 2. Most likely, when we say adverse events, we're talking about airway patency, respiratory drive, protective airway reflexes. Additionally, children commonly enter a deeper level of sedation than intended, so we got to watch out for that.
Well, thank you, Danya, for taking us through this lesson. There's a lot of great pearls and additional resources in the lesson that our listeners should check out. In general, I think when we think about procedural sedation, we have to think about the level of sedation that we're providing. And of course, the deeper the sedation, the higher rate of complications, mostly related to hypoxia. A lot of the preparation comes before the actual procedural sedation, which is assessing the patient for potential high-risk characteristics, and of course, preparation in general for the agents you need to use. In terms of patient assessments, we may have to consider their comorbidities and careful airway assessment, as well as any prior history of difficulties with anesthesia, allergies, etc. Using a checklist is a great way to ensure that you cover everything to ensure a safe and successful procedure. Now, in terms of pearls for the actual sedation portion, using capnography is helpful to monitor end-tidal CO2, since you could see bradycardic hypoventilation, where the patient could have an elevated end-tidal CO2, or hypopneic hypoventilation, where the patient actually has a lower end-tidal CO2. But as we mentioned, hypoxia is the concern and the most common adverse event. And so it is recommended for patients to receive supplemental oxygen during the procedural sedation. In terms of medications, you have many classes to choose from. And the article goes in depth on the different classes and the pros and cons of which. A few pros on that are that, remember, opiates only provide analgesia and not sedation. Whereas propofol, which is commonly used as a sedative, does not provide any analgesia. Whether you are using ketamine, because of its combination effect on analgesia and dissociative sedation, remember that it can cause laryngospasm. The other pearl that I think it's important to remember is that if the patient has already received some sort of opioids before your sedation, that can increase their risk for complications. And so you can consider either using a local anesthetic for additional analgesia during the sedation portion or waiting till after the peak effect of the opiate. So definitely check out this lesson for additional refresher on procedural sedation. For our drip box this month, it is on cefepime-enmetazobactam. We are all familiar with cefepime, which is a fourth-generation cephalosporin, and this other drug, enmetazobactam, is a novel beta-lactamase inhibitor. And this is specifically designed to treat gram-negative infections that have high risk of resistance, like ESBL or hospital-acquired pneumonia in Europe. The dosing is 2.5 grams IV every hour as an extended 2-hour infusion. You're going to need to use this for 7 to 14 days. It should be adjusted for renal impairment. It can cause elevated liver enzymes, hypersensitivity, and even neurotoxicity. And it's also important to avoid any carbapenems for resistant UTIs. And so pay special attention also in patients who are elderly.
And last but not least, our Tox Box is mefloquine toxicity. Mefloquine is an antimalarial drug used for treatment and prophylaxis of malaria. Given its lipophilicity and easy entry into and accumulation in the CNS, it can cause neuropsychiatric toxicity and overdose. It may also have antimuscarinic effects. Patients taking regular dosages are going to have nausea, vomiting, and diarrhea, so obviously that's going to happen with your overdose. Patients may also have cardiac effects like bradycardia, QT prolongation, and rarely torsade de pointes. As for the neuropsychiatric symptoms, patients may come in with simple things like dizziness, vertigo, headache, but that may progress into seizures, encephalopathy, and hyperactive delirium. It may also cause hypoglycemia. Knowing all that, the workup should include a POC, glucose, ECG, basic labs, looking for co-ingestants. If they present early enough, then charcoal is helpful to treat their symptoms. If they have a lot of antimuscarinic effects, then consider physostigmine, and dialysis is not helpful. A really important pearl here is that CNS effects may be delayed up to 24 hours, so you must observe the patient, even if they come in initially asymptomatic.
Every drug has potential side effects, and in this case, bad toxicity.
Well, thank you, Wendy, for taking the time to go through this issue with me. I've learned a lot. Our dear listeners, I hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decisions publication, as well as our podcast, always informative, often enlightening, and never boring.
Reach out to us on our social media. My Instagram handle is at Dr. Danya Khoujah.
Mine is at Dr. Wendy Chang.
And until next month,
bye-bye.